So good afternoon and a very warm welcome to SSTC on MIGS, a long sought after event which we finally managed to put across together. And we would first start with a short talk on gonioscopy by none other than Mr. Shoykot Dotto, the national head of glucose in India. And following that, we'll have a small interaction session where you can ask him all your queries that you wish to ask him. And after that, we have our most esteemed guest this afternoon, Dr. Saiban Sethi, who would be speaking to you on optimizing glaucoma medication, the two M's, medicines and MIGS. So over to you, Shoykot. All yours to start off with surgical gonioscopy. And after this is over, we shall start the hands-on. I think you all have already got your numbers for the hands-on. So that's how the whole thing's going to move on. Thank you.
Good afternoon to all of you. This is the first of our presentations or our workshops in the eastern part of the country. I am Shoykot Dotto. I actually am trying to pronounce it as Shoykot Dotto after a long time. Being based out of Bombay and traveling across the country, Shoykot Dotto bola chance paoa jay na. Shoykot Datta bolte bolte motamoti I got exhausted. So I belong to the city, but of course I am heading the launch of Glaucos, which is a US-based organization who has been innovating the whole procedure of MIGS in collaboration with Ike and pulsing in US for the last 20 years, from 1998 onwards. I am launching the organization in the country. Of course, I have Shutanai, who is representing the surgical team in Eastern Zone. And I'm really very feeling good that almost after a period of one and a half years of commercial launch of this concept in India, from 2022 onwards, we have really got some good experience, even in Indian setting. So I am going to speak a bit about the international as well as the Indian experience, and then going to quickly to the surgical gonioscopy, which is, of course, the backbone of MIGS. And I think Dr. Chandrima Paul, I have to really thank her a lot that she has not only started the first procedure in the Eastern Zone, but she has been really following me up for the last 2-3 months. We have planned it to organize this workshop. Thank you, Dr. Paul. So just to give you a background about Glaucos, Glaucos is not a very old company, but started up from 1998, but we are fully with MIGS in general. Even the term MIGS has been coined by Glaucos in collaboration with ICAMED long back in 2000, where we have tried to find out the space for this procedure. We started, of course, with generation 1, which you may have seen or you will see a little bit in India, but we may move out of this because of drug regulatory, some requirements which we will not be able to follow up globally also. So we are currently having the iStent inject in India, and actually we are moving from iStent inject to iStent inject W. So this is the 3 modifications, or you can say generations, which we have developed and already launched. And then, of course, in 2022, we have got an US FDA approval for iStent inject Infinity. Of course, the indication is totally different. It is for severe glaucoma or refractory or severe glaucoma. But the first 3 generations, or iStent inject W, which we will be talking today around, will be for the mild to moderate glaucoma. Not that Glaucos, of course, we started with glaucoma only, but in the last, I think, 5-8 years, we have moved from a space of glaucoma to retina and also cornea. Cornea, of course, we have taken over Avedro. That's why the cornea is with us. For retina, we are still in the process of development. And if you see the segments, we are, of course, we are more into the implantation devices. That is our key strength. And you will find a lot of these implantation devices also being merged with pharmaceutical products. That's where we get the first approval of iDose 2 weeks back in US. And we are also working on some biosensors, mainly for glaucoma, but maybe in future we can come up with something else. So as on date, I'm very happy to share that we have got the US FDA approval for iDose TR, which is the travoprost intracameral implant, which currently is getting launched in US, but of course we are having iTrex, which is the extended release of travoprost. That means the duration of these implants use or stability in the eye is going to get increased with extended release, and then we will come up with iDose ROCK, where we will have ROCK inhibitors inside the implant. So this is basically about glaucoma in quick snapshot. With iStent, we are almost around 15 years plus of experience, with almost around 1 million eyes already been implanted with iStent in the last 15 years, with 250 odd publication, most probably the most published MIGS available globally. Just quickly, I think the video should run, yeah. This is what animation video of iStent inject looks like with 2 devices. I think most of you must have seen this somewhere or the other. Yes, it looks very simple as far as the implantation is concerned. But the story is actually, the start of the story is about visualization, which is my topic now. Now, I will not take you through the full video. I will just try to focus on few of the points why visualization is so critical for us. It's typically after a phaco surgery. You put in cohesive viscoelastic, put some cohesive viscoelastic on the cornea, tilt the microscope, or rather tilt the head away from you, tilt the microscope towards you. If you see, are you able to see yes. Are you able to see the structures of the Slem's canal or the trabecular meshwork from the back? Are you able to see it? So do you think this is a good view of the trabecular meshwork? How many of you think this is a very good view of the trabecular meshwork? You may not be very clear, so I'm just continuing with it. This is not the very good view. So you have a view of the trabecular meshwork, but still it is not the best view. So what we will have to do, what changes he is doing, I will explain it to you later, but we will try to work towards the best visualization. Now you see the angle. Is it better than the earlier one? Because we are able to see very clearly the scleral spar, which is the whitish line. Then there is a very clear red portion, which is actually the trabecular meshwork. And of course, Swabbe's line, you may not be able to see it here in the screen, but you will be able to see in the actual view. Now, if you can see, this is all almost facing towards you. This is called en-face view. If you have to remember one word, is en-face view. En-face means it is actually on the face. Typically, if you can just imagine, I would say, can you just put the lights on? We have never seen it so closely. So if I have to say, all of you, you may not be able to see it, but just try to understand the concept. If you have to see this portion, which is a very small portion in front of you, and I keep this below, just below, will you be able to see it better? Or if I keep it here, you are able to see it better? If it is here, are you seeing it better? Or if I keep it here, are you seeing it better?
Okay, you're trying to see this side or the top?
This side.
And from below is better.
This is better? Or this is
Can't
better?
feel it. Neither of them. You can't see this side.
Now, this portion,
Oh, you're showing us. Okay.
side.
Yeah.
And if I show it here, and if I show it here, which is better? It is near.
Near.
That means alpha is straight view, and front means maximum magnification. ये दोनों, if you have these two, and if you are able to see this, then putting a nail on a straight view is easier. If you have to put a nail somewhere here, you may be doing it, you may be with an optical error sometimes, you may think you are in the right place, you may go down or you may go up. And believe me, you are working in a zone of 275 micron. Our trabecular measure, which is the where we want to do anything, whether it is bang, gap, ice-tail, whatever it is about 275 micron. And if you miss it by 100 micron, you are on a different place. And for the success of MIGS, there is not much of challenge. There are only two challenges. One, if you have not selected the right patient, and second, if you have not implanted it right. In both the cases, it is not going to work. There is no 50% to it. Either it will work or it will not work. And everybody asks, what is the failure? What is the challenges of iStent procedure? Dr. Chandrima Paul also asked initially. I said there is only one. It will work or it will not work. If you have not implanted in the right place, it will not going to work. Because believe me, this space, although I showed it very easily, this place is very small if you are not magnifying it very well. If you can magnify it, I will take this video off. This is one of the surgeons from India. Of course, don't look at the name, but that name is not the surgeon, but of course, it is from the same institute, Dr. Sirisha Senthil. It was actually for Rashmi. If you see, I will not show you the surgery fully. Look at the trabecular meshwork. Are you able to see it? Although I don't know the screen is very good. Are you able to see it much better than that? And if you have to do anything in that space, if you have to do, just look at this. Just look at this. Visualize this. Remember this scene. This is the best view which you can have in all your patients if you want to. For that, you have to practice. You have to work hard. You have to, maybe in your cataract patients, use a synca hook and have this visualization. Of course, this was a G1 implantation. I'm not going to take it to the end, but yeah. This is one of the toughest of the iStents as far as the procedure is concerned. I think Dr. Chandrima Paul did the toughest first. So I am taking this off. This is not my intention is to show the implantation, but it is about showing the importance of visualization. And if you can implant it well, this is what happens with 2 stents. And when you put 2 stents, this is an Alex Wang video, which is, of course, a research purpose, aqueous angiography study, which speaks of if you have implanted the right 2 stents in the 2 places, how will the outflow improve? In fact, Dr. Sri Ganesh actually is going to publish a paper on triad, which is a triad of visualization, whether this is going to work or not, iStent. And one of the 3 points, one is, of course, oozing of blood, which will come from the stent. The second is blanching. And you can actually see a blanching in most of your patients if you have practiced it well, of course, over a period of time, where you will see this aqueous flow happening, and your sclera, you will find a whitish flow. All the blood vessels are going to get white when you push in a lot of aqueous in the AC. After the iStent is done. And of course, third one is a little bit more complicated. It is more about the OCT, but that you can keep it for the next day. So now coming back, why we are very curious and or serious about the visualization and implantation in the right place. This is basically the Slem's canal. Slem's canal is not just a canal. it has a pumping network. That's why Slem's canal, whatever goes inside it, it actually is circulated 360 degree in the eye. And the whole thing happens because of the pumping network mechanism of the Slem's canal, as well as, of course, it has some phagocytic activity, as well as a blood aqueous barrier which can be contributed to the pathophysiology of inflammatory ocular diseases. And that's why when you implant anywhere, even 2 stents, the questions comes, if it is such a 360 degree and you are putting 2 stents into 360 micrometer, so it is almost around 80 micrometer, how can you think that the whole Slem's canal, or how can you see the aqueous outflow is very good? We have actually Kevin Gilman has done an OCT, NG-OCT study, anterior segment OCT study, where he has actually seen the size of the Slem's canal, which is almost around 100 micrometer. He has tried to see wherever the stents has been pushed, what is the Slem's canal size after 12 months, and also on 180 degree opposite to the position of the eye stent inject, or the 2 stents which is there. So this is, which is just on the stents, and then a little bit away from the stents, 5 micrometer away from the stents, and then it's a 180 degree, and which is seen that the Slem's canal size has increased over a period of 1 year, 75% increase in this space, and there is still a 45 to 50% increase in the size of the Slem's canal in the opposite limbus, which speaks of, if the Slem's canal function is intact, that means it is pumping action is intact, it will actually ensure the flow is happening across, and you can see the same outflow from 360 degree of the Slem's canal in the trabecular meshwork. This ends up on the theory part of it. Now I'll quickly go into very specifically on, I've taken most of it, of course, but I would say 85% cause of success or failure of MIGS surgery is having the best view, which I have already shared. So understand the anatomy, of course, you know it best, but get your own prism and understand how to achieve optimal visualization, which I'll take you through quickly. And then we will maybe, I don't know, based on the availability of Shaiban. So we will have the talk and then go actually practice. Today, I would request all of you who have not done it, of course, I'm seeing some faces who have already done it. It is not for them, but at least who have not done it, have some visualization practice first in any of the centers, wherever stands which is there, how to handle the prism in a very stable way and how you can visualize it in the model eye. If you can achieve that, and if you can practice that going forward tomorrow onwards, I think you have taken the first big step in the management or rather in the adoption of MIGS. As they say, as I was sharing about, we will try to do anything in this space, so you will be able to see the scleral spar, that's the whitish part which you are seeing, and you will see the Swabbe's line. Swabbe's line may or may not, but scleral spar should be seen, because if you are not able to see the scleral spar, you are not knowing what is the type of glaucoma which you are managing. Is it really open, or is it having, is it a closed? Because you will not be able to differentiate maybe many of the times. In terms of the anatomy, in terms of angle structures, you can go through the gonioscopy.org, where there is a very detailed understanding about this. I'm not going through it, but what I'm going to do is the next step is about the microscope tilting and head tilting. So how will you, anybody can just say, how will you remember this? Which one will go away from you, which one will come towards you? Huh? Eyepiece is towards you. And patient said? Okay. Yeah. Perfect. Direct. Just for my own understanding, it is layman's understanding. I say, microscope is mine. It will come towards me. Patient was never mine. So it will go away from you. If you remember that, I think that's the best way of remembering. But on the per degree side, you have to be one specific is the microscope tilting should be 35 degree. That is for sure. And you can actually use a app in the mobile, either if it is an iPhone app, you have a measure app. If you don't have an iPhone, if it's a Google phone, you have angle app. Whatever it is, you will have an app which actually shows you the angle. You just put it like this below the ocular. You will find that you will actually maybe have to do a 30 degree, 35 degree. Once you have done it, you just have a marking on the handle of the microscope. Do 3 markings so that you are sure that this you don't have to measure every time. And your sisters and your staff nurses should also be trained on this, because many of the time you may not be able to change the microscope yourself. They will help you out because you are sterile. That is, first is the microscope tilting. In terms of head tilting, how we say, it is not how glaucus we try to push it across, almost push the patient on the ears. That means almost try to put it on the ears. It may be uncomfortable for you or even for the patient, but make it there and try to see the angle. If you see it's a little bit more, you can always tilt it back a little bit. But why this? Because this will actually give that, which is the view which we want. What is the name of the view? On-fast view. Remember this, as far as MIGS is concerned, you will listen to the word on-fast many a time. If you have to have the on-fast view, have this. But with this, you will have 2 challenges. One, your working distance goes up. So many a times, you may not be able to stabilize it with so much, so you may have to look it. And the second is, your ocular will actually go down, so you have to adjust the oculus and try to make yourself comfortable. 2 things which you should not do. One, never bend your back to adjust yourself to the view. Because you may do it 1 minute, 2 minutes, but if you have to do the procedure for 20 minutes, believe me, your hand will get shaken. That is one. And second, don't try to adjust any of your necks or anything to establish your good view. You try to change the chair size. You may have to put it up a little bit, or you may have to put the table down a bit. That's okay. Do any of this to have a stable, straight, upright sitting when you are seeing with the prism and the device. Because both of them will not, believe me, you will not have any support. You cannot put the hand here, or you cannot put anything here. You have to have both the hands floating. So if your sitting is very stable, you will be able to do this implantation procedure very easily. If you are having any body posture changes, and after 15-20 minutes, initially you may take 15-20 minutes for this procedure, then your hand will start shaking, and this whole procedure will be a little bit tough to manage. That is second, and of course, as I said, the staff nurse should be able to help you in terms of, we have gone through it. Now last piece, and we will finish it off with this, is the gonio. So when you are putting the, placing the gonio, as I've said, poor prism view and angle. If you are you may have a faint view of that trabecular meshwork. What you should do and what you should not do is, you should not just see, he is trying to place the prism towards it and make it much more easier. It is not the right view. It is basically about prism movement only should happen either towards you or away from you, but not sliding on the cornea. If you are able to see it, try to change the prism up and down to have now you see it's a very sleek view. Although it may look good, but it is a compressed view, and this is not the right view for implantation. It may be a very good view for diagnostic reasons, not for implantation. See, this is the eye prism, or any Swan Jacob. Do you think this is looking into the other Of course, it is written, so the question does not make sense.
I have a question, can I interrupt?
Yes. Now,
This procedure always has to be done from the temporal side.
good. Yes. Yes.
Can't do that practically with your.
No, that is not the reason. Of course, you can do a bit of superior procedures, but why it has to be done from the temporal side? Okay, head tilt. Any other reasons? Any other reasons why it?
Microscope is tilted like this, the head will come in this side.
Okay, that is what positioning. Is there any other? No. So positioning. Anything to do with the anatomy?
Eyebrow will come in the way. Eyebrows will come in the way.
That is positional anatomy, anatomical nasal or anything to, it is, I'm just trying to make it a little bit more, yeah. Can you please be, can you be loud to everybody? Why? The number of collector channels is the maximum in the inferonasal and the nasal channels. Number, it may be 30 to 40 are here. Other spaces are less. So all the MIGS surgeries, all MIGS starts with here. Whoever, of course, goes 360, that's a different issue, but most of the MIGS will be here because you are able to connect to your collector channels maximum in this space. That's why all the surgeries will be around this and temporal sitting. Of course, you can do a little bit of superior sitting, also manage that, but your positioning should be in the temporal. So if you're doing a left eye, it's difficult. You may change a position of the head and all those things, but it is tough. Now coming back, you have seen that this is the best view. So getting this view is important. As I said, I don't want to repeat it. So ensure your assistants are knowing the procedure or turning of the microscope very well. And of course, the patient you can place a pillow on the other side of the patient's shoulder if it is needed. I have not needed it. I have not used it ever in the last 2 years. You may use, intracameral myotic to have the people managed, and then you can, of course, you should use cohesive visco. This is one point, yes. Very important is for the first 5-10 surgeries, at least use the best cohesive visco available to you. If it is Hilon GV, somebody actually uttered Hilon GV, I was very happy because people don't want to use Hilon GV so easily. Hilon GV or Hilon GV is not available even if it is Hilon GV Pro, which is 1.8. Hilon GV is 1.4. Never try to compromise on this in the first 5 to 10 surgeries because it has 3 effects. One, it of course deepens the chamber, so you will have a very good view of the angle. Second, it has a tamponade effect when you are actually implanting it. If there is a blood ooze comes out, it will give you 10-15 seconds to have a good view and finish of the surgery coming out. If you don't have it, you may have a problem. Third, if the stent, and it is more required for eye stent, it may not be for other procedures, if the stent drops off, it will be in the Hilon GV, it will float in the Hilon GV, it's so thick, it will not even move. You can just go and pick it up or you can rethread it. We will learn that when we are getting trained for eye stent inject. I'm not going to the topic now, but you can do all these things if you are using Hilon GV inside the AC. Even on the cornea, if you are using a good cohesive visco, Hilon GV, again in the same case, you will have a very good coupling of the eye prism on the cornea. Because we are going to use the refractive part, we want a very good coupling so there is no issue on the refraction as well as, of course, the visibility. So having very clear view is very critical for this procedure, and Hilon GV is equally critical. That is one point. Second is, of course, this is not in the slide. People may ask, do we do it on topical? I would say initially, first 5 cases, remember, and I would say request to you, do it on block. Patient may move his eyes or her eyes at his own discretion. But at the moment of whether doing bang or your eye stent, at that moment if he moves the eyes, you really don't know what is happening. So please don't do it under topical initially, at least 5, 10. Once you have become masters, you can go ahead without topical. As I said, magnification has to be the maximum in your microscope. Illumination, yes. When you tilt your microscope away from you, if you see the whole light, the whole portion or the full portion of the light is not coming to you. It will get in a different angle. So it's better you use the maximum illumination. And it is my own, I have observed it very clearly, that when you are seeing the angle, try to keep this trabecular meshwork on the upper side of your view. Don't keep it, so if you're centering the microscope, the trabecular meshwork, if you put it on the upper side of the view, you will find more amount of light coming in. It will be much more visible. Rather than if you are putting it here, you will see a little bit. You can try it yourself. But the most important part, if you are keeping it low, by chance while you are implanting or doing anything, the eye go down, it will actually go out of your view and you will do a blind surgery. Only second request after viscoelastic, don't do anything in the angle if you are not able to see it at the moment when you are doing it. So when you started, you have seen it, then you started off and then you are not able to see it, don't do anything. Stop. Get the view back and do anything there. All the mistakes, and these are all practical things which I have learned in the last 1.5 years, all the failures of eye stent implantation which I have seen is because of 3 reasons. One is visualization is not perfect. Second, when they are implanting, at that moment something happened, maybe because of the whatever is the reason, the stent touching the incision site or something happened, they lost the view at that moment, but they still continued either doing an eye stent or implanting it. And I've seen most of the cases this has failed. Be calm, be quiet. I will go back to the last, again to the Dr. Rashmi's slide, and I think the calmness of your hands is very important in this process. Other things, of course, when you are visualizing, of course, you have to remove when you are inserting the device, first have the magnification low, out magnify, focus on the incision, insert the device, then again re-magnify, and then go on to do whatever you want to do in the angle. So while you are inserting, it's better you off magnify and go into the focus on the incision, because that will ensure that you are not hurting the incision or you are not able to struggling to insert the device, whether it is eye stent inject or bang procedure, whichever you are doing. And as I said, last point, trabecular meshwork should still be in focus as you begin stent procedures or any procedure. Practice intraoperative gonioscopy, and my last 2 lines. One, practice intraoperative gonioscopy, practice the turning of the patient heads, holding the gonioprism, and practice locating and visualizing the anatomical structures, and mentally practice the implant procedure. I think this practice is very important if you want to really start doing it. So what are we doing today? We are going to have a visualization basically with the iPrism or iPrism SX as a process. Then you will practice a bit of in the eye model. This is what you are going to do. Practice it. And the second is, of course, you will do some procedure. And what are we going to do tomorrow? Or I think Dr. Shukarna already answered me even before we started. I think don't start a MIGS procedure. You don't have to start a MIGS procedure for tomorrow. At least get your prism, have the visualization, and practice it for at least 15-20 cataract surgeries. Whenever you are doing any procedure, have the sterile prism in your back end. After the finish, if you finish the procedure, go on to have a visualization. Because I think in the next 10 years, you cannot really ignore surgical gonio or MIGS in any of the ophthalmology. I think that's my understanding. I'm not the best person to say this. You are the best person to understand it. Thank you. That's all. It is implant or the prism? Prism costs 6,000 rupees plus taxes, which is ours. You can get it. I think another cheaper version is also available. I don't know. I think available. Somewhere is available. No, that is ETOable. iPrism or iPrism S6 and another work. And as far as the implant is concerned, iStent, actually I'm not speaking out because iStent we are having very few stocks and we will not replenish it, which was costing 42,000 plus taxes to the doctors. So iStent Inject W, which is the only version which will be available, is 95,000 plus taxes to the doctors. Of course, the other prices are based on the how you are packaging it.
Each of them has two
Stents.
and they can be used in one eye.
Yes, it has to be used in one eye. Any other questions on direct gonio?
So that was wonderful, Shoykot. I think I also learnt a lot after over a year of implanting the first stent. But that was really wonderful. One thing is that about the microscope is, if you go for the recent microscopes, they have the markers. You don't have to mark it. Like I use a
Leica.
Topcon. The Topcon has its own markers. All I have to do is tilt it to that mark. The Zeiss models still don't have it. But so if you
Leica
have
have it. Leica have
has
it.
it. Okay. So if you have one of those microscopes, you don't have to, put a mark every time.
Yes.
And second thing is about tilting the head the other side. That is best if you have a trained person. Like I have a trained person who knows exactly how much to tilt the head. So I don't have to bother my head about tilting the head because every patient is going to be new, but your assistant is not going to be new. So train your assistant to tilt the head just that much, how much is required.
Perfect.
And third thing I wanted to say is about the hands-free gonioscope, which actually they introduced. It was first in the GSI that we saw this, and we were absolutely mesmerized by it because then you have your left hand free, and you can just put it there, plonk, like the Eiffel Tower, and you can look at it.
Yeah.
And they sell it for 6,000 something. Have you brought some?
6,000? No, we don't. We can get it because
Yeah,
Sutana
but
is
then I had
there.
asked them to
We
bring a
make
few
it,
so
make
that
it.
if any of you want to buy, you can buy it out here from them.
You can just
Because-
talk to Sutana and we will get
so
it.
you can talk to Shutanai, he's the person. And that is really, really helpful. Instead of, holding, we did that because we used to do goniotomy at that time. And we used to hold the Swan Jacob with one hand. And I tried to do it with the Swan Jacob only. But the first time on the table, I saw that Sangeeta had brought that, one of their associates. And I used that. I kept the Swan Jacob, which I had been using for years. And I took that, and with that only I implanted the iStent. It is that easy to use and a good learning curve. So try to buy that, and you can ETO it and use it. I think I could use it for 3 or 4 cases. I could use it. So you can use it. It's
Frankly speaking, if you can maintain
yeah.
it as your own,
yes.
it can be done with 30 surgeries also. So Dr. Amit Pandey has not bought after the 2 which he has bought.
But then
and he has
he's
already
really maintained it well. I must
maintain.
say.
You have to single-handedly
Yes.
maintain it.
Yes.
It is not nothing. You have to just do. You have to remember only one thing. You cannot wash it other than distilled water. Don't even use a saline water. Distilled water washing. Just rinse it. Don't even scrub with anything. Air dry it. Put it in a. It comes free because it is disposable. We don't provide any case. So if you can get a case out of it, put it in that and go for ETO. Don't scrub it. Don't try to dry it with any cloth. No cloth using. And I have started doing another one thing is that while you are doing in the OT, put a small ball of distilled water, put the prism in it. While you are using it, use it, and then again put it back. Because by the time you finish the surgery, your visco is stuck up. Then you tend to wash it, and then you tend to rub it. But if you put it in the water directly, it will not get stuck even in that period of 15-20 minutes. So you just wash it in the distilled water and air dry it and keep it. If you maintain it, Amit, as I've seen, at least has done more than 50 surgeries with 2 prisms till now.
Wonderful. But
Not
you
good
also,
for me,
yeah.
but it's okay.
And then you also get a cheaper version, which is available with
Volk.
Yeah.
You can
so you
try
can
it.
buy it from them. That's, I think, 4,000 rupees if you want to cut
Precisely.
down on the
Yeah.
price. Yeah. And about the viscoelastic, actually, I feel Hilon is the best.
Yes.
The best. Not Viscoat, not anything. Hilon.
Viscoat,
But,
no.
yes, absolutely no.
Viscoat, no.
Yeah.
It is not because of the quality, it's because of the whole, it is a
Yes.
disposable.
Disposable.
Don't use a disposable
Yeah.
one at all.
But the first one I had done was something else. I forget. What was that?
So that is biohyular,
Yeah,
which is
yeah,
a biotech viscoelastic of 1.4.
Yeah.
And that I think Dr. Vanita and me have found out
Yeah,
from
yeah.
anywhere. If you don't have Elon,
Yeah.
what is the best alternative. There is one from Care Group which is Hyaluron 1.8.
Yeah.
But frankly speaking, I would prefer a Biotech 1.4 because the viscosity is good and most importantly the transparency.
Yeah, transparency is very good of
Very
that.
good with bio.
And it's 1/3 the price of the Hilon.
Huh.
So for a start, actually, you can buy that. It's available with the Care Group.
No, that is for Hyaluron you are talking about.
Yes, yes.
Hyaluron is also okay. And you can take a Biotech which is also the similar price.
Similar price.
Biotech is not promoting me, don't worry.
Yeah, because to start with, you know, it might become very expensive to use Hilon. And one Hilon won't do, you might need a second one. So the best thing is to use that. And then once you're comfortable, your patient is comfortable, then you can switch over to all the luxuries of life that you can do with MIGS. That's it.
That's what I said.
Pardon? On the cornea, no, you use the normal methyl cellulose which we use.
No,
That's fine.
in the cornea also I would say initially use a cohesive visco.
No, I am asking this specific question in relation to the Prism X.
All everywhere, if you see, I'll just show you why it is different. I'll show you one.
Besides the visualization part, does it damage?
No, damage is not an issue. Basic.
Number of times we use it.
No. It is nothing to do with that. Actually, I will show you why I prefer. When you put, sorry, I'm not able to. If you put a cohesive visco on a cornea, you will find it is staying there. It is not dropping off. So even if you put 2 drops of cohesive visco, it is enough. But if you use anything other than the cohesive visco, you will find it will slightly slow down. Even Hyaluron 1.8 I have seen, it goes down, but BioHyaluron 1.4, it stays there. That helps you in optimizing the use of visco. And when you put the prism, it will just be there. It will just be there. Dr. Pandav actually did that and actually is creating a video which says, Saikat, I am really relaxed with the prism ever. I have never thought that the prism will stay there in a tilted head. Try to understand, this is not a straight head. It is a tilted head. So actually it is going to slide down. It is so light, and if you use a good visco, it will be there. You just have to support from the back so that it does not fall off. Nothing else. And why it is critical, it is not about hands-free, it's not a lavishness or I want to just have it. It is because the 2 things which will hamper your visualization is a pressure of the prism on the cornea. The moment Swan Jacob comes in, you have to hold it with a hard hand, you will unintentionally put it and there is stria. There is horizontal stria, which will change your visualization. And the second thing, when the device goes in, you will find there is vertical strias coming in. That you should know that you have hit the incisions. So if you're hitting the incisions, there will be vertical stria. If you're putting pressure on the prism, it's a horizontal stria. So to get rid of this horizontal stria, we thought that hands-free is very good. It is not for that we want to just become much more fascinated with technology.
Yeah, that's a good one. I don't know about the one from Vogue. I haven't used that, but I've used this and it's really good. So if you have any other questions, you can ask, or else we'll move on with a video from Dr. Saiban. She must be just entering any moment.
Okay.
So we'll just start off with that video while
you have that?
yeah, I have that. It's on that thing. So
Any questions?
any questions that you want to ask?
Before you do, you don't have questions.
If you lose your strength and which is floating and you have retrieved, can you reload it?
Yes, you can. Yes, and that is, of course, is very costly. I say to the scrub nurse who used to open, we used to train them how to open the device. I said, if you don't open it right, then your 60,000 is going into the drains. Then next day onwards, they are very serious about it. Inside the eye also, we will have a training of you when we are doing a eye stent training. So as an organization, we don't just leave the device with anybody. So for the first 5 surgeries, one of the surgical specialists, so Sutana is our surgical specialist in East Zone, he will be there in your OT to train. And 1 hour prior to the surgery, you will have a training on implantation, rethreading, regrasping, all this process which you will learn so that even you can do it in the eye. So rethreading can be done inside the eye, or we will use a retinal microforceps to pick it out, put it in the sterile white plate outside, put a visco, drop of visco and rethread it in the, that can be done. So I think Sahiba will be able to the best person to express these things.
Each pack has one injector.
One injector, two stents. One injector will have two stents, one back then. Yes, it's a mechanical. That's why iStent inject and W is a technological advancement where you don't require, I would say, physical energy. There is a click into it. You click, one goes. You click, second goes. There are 4 clicks actually, although there are 2 bullets.
So you don't need to take out the thing between the two.
No, 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 no. Go in. So that's why actually, since I don't know. No, this is the iStent. Sorry. No, I think I don't have the surgical video. I have not kept it. I think Sahiba will show some video. I think the video.
The
Yes.
video is there.
I think that's right.
Yeah, we can show that surgical video.
W is actually we have a wider flange than the inject. The flange means once the video is shown, I'll show it to you. It varies. It is average. We have seen on a meta-analysis is around 30 to 31% over a period of 5 to 6 years. But it varies. If the initial pressure, baseline pressure is very high, then the percentage is very high. So, and if the baseline is very low, like 18, 19, so typically you will achieve somewhere between 13 to 14 or maximum 15 with all the mix across. Because it is the episcleral, no. Precisely why there is no chance of hypotony is the episcleral venous pressure. You are not creating a side port, you are actually using the natural pathway. So episcleral venous pressure is going to be a safety net. So no MIGS should have hypotony if it is done right. If you are doing some other, you cutting in the wrong place, then the problem starts, otherwise it should not. In fact, hyphema is there with many of the MIGS where you are cutting the trabecular meshwork, that is goniotomy. But with iStent, there is a backflow, as Dr. Sadrima says, there is a backflow of the blood, heme, which is there for 15 to 20 minutes maximum. No, and that's why it's actually been the best MIGS available to be combined with phacosurgery, mainly premium IOLs. Yes, premium IOLs also, why they could use it, that you don't have all these visual acuity challenges in the next day. So you are having a 6/6, if you are can get a 6/6 view, it will not hamper a 6/6 view next day. And that's why it is combined with most of the premium IOLs, even in India. iStent can be done. But if you do other MIGS where you are doing a goniotomy, you will have hyphema, and actually there are few MIGS where you actually say that 1 month, 6 to 8 weeks it requires that hyphema to settle down. That's why I said your question is very good for me. For the question. No, this is the scoring point for iStent for the last 15 years. It can be used in phakic eyes, non-phakic, pseudo-phakic, as well as with cataract, standalone also. And it has seen. Surgical, that I said, 2 surgical complications can happen. One, you are implanted not in the right place. And second, you have implanted it and it has got embedded in the trabecular meshwork, which is called over-implantation. These 2 can happen. In any of the cases, there is no complication to the patient because it's an inert titanium. We have not seen, of course, I would not say we have not seen one case just now, as I'm talking with Dr. Kaivan, we have seen a little bit of, I'm yet to get the full details of it. We have seen a little bit of uveitis. The patient was having recurring uveitis before also and after this. Unfortunately, he was having this quite a long time, and then he has decided to explant it. This is the first time. Loose, yes, it can be loose at the time of implantation. So what we do is a procedural check. If you have done the procedural check, it will never come out. If you have not done the procedural check after the implantation, which many people actually tend to not do, because they think, ho gaya, I've implanted it, I will not do anything to that, there is a risk. If you do the procedural check, which surgical team will say, if you do that, there is no chance that it will come out afterwards. On the table, yes, because if you are under implanted it, it can. No. This is not, good question. This is not, strictly not a substitute of trab. MIGS has come into the picture to postpone trab and maybe halt trap for lifelong, because if a patient is around 50, 55, 60 and you do a MIGS surgery and you don't need to do a trap up till 70, 8, 9, 10 years, and then at 70 you may think that why should I do a trap at this age? So you can postpone trap. It is not to all. That's where the whole concept comes in. I think the whole conflict came in when MIGS came in. The IOP reduction percentage of traps and MIGS. How is it beneficial? Why should I do it? Purpose is totally different. It's an early glaucoma where you cannot manage with drops or the patient's adherence and compliance. I don't want to quote. It is not an SLT. If you globally, if you see, यहाँ पे तो SLT होता नहीं. No. What we have seen globally, SLT is done first. Drops, quickly move to SLT, then move to MIGS. Because SLT has not sustained for more than 1.5 years. It's okay if an SLT can make the patient good. Why should I do a stent at all? If SLT is not available or you are not able to do it or you have done it and not working, go to the MIGS. So I think this whole pathway is a very continuum process. It is not to replace anything, and nothing has come forcibly. It's a spectrum, yeah. I used to say it and I used to push for it. Now I don't think it's not required. Globally, they have stopped it actually. Unfortunately, my first patient was on blood thinner and we could not implant it. So I was afraid for 1 year. I pushed everybody to stop blood thinner because my first patient was like that with Dr. Nitin Deshpande. But I think now it's okay. You don't require it. You will be able to see. You will not be able to see the two spots which I have shown. The flange. You will not be able to see. It will be lost in the trabecular meshwork. Actually, over implantation होने का problem क्या है कि you will not see anything. Under implantation will be something is floating. You will take it out and put it across.
You want the radiologist who is doing MRI, will it pull the eye?
Yeah. Actually, if you ask me over implantation, we don't suggest to.
I'm talking about overall, non-over implantation. If it is there in
No. MRI, is that MRI safe? 7 Tesla. So we give a certificate. We give a certificate of 7 Tesla with the procedure box. 7 Tesla. Tesla, which is the highest, which we don't do. In India, it is 1.5 to 3. Nothing will happen. Nothing is going to happen. It's a titanium inert, and we have this actually in the box. You will give it to the patient. They should carry that certificate if they want to. Perfect timing. Why should you be sorry? Delhi weather is not in your control. I know Aditya is control of Delhi, but he is not in control of your Delhi weather.
Well,
Good time.
good afternoon and welcome, Dr. Saivan. You're coming from so far. I know the flights are delayed and it's difficult in this season. So may I please request Dr. Chandrima Paul to present the welcome bouquet.
And this is some mishti from Kolkata.
Yeah.
Which you can take back home.
So
Move on to your talk, I think.
Netralay. My MIGS journey started about 4 years ago, and I've been consistently doing it from the past 2 years. And I've conducted various workshops, done live surgeries, and I'm really grateful to Chandrima ma'am and to Sekat to have thought that I was worthy enough to be here in front of all of you. So I'm going to be presenting my talk on how to optimize medicines and MIGS in our practice. It's going to be lightly touching upon how we initialize and optimize our medical treatment, as well as where MIGS fits in our practice. Maybe give a few clinical scenarios which will probably make it a little clearer on the direct application of MIGS, which kind of cases you should be choosing, which kind of cases you should not be choosing, and all of that. Now, we all know that we have various options of treatment in glaucoma, which has been available to us. Medication and SLT for the initial less invasive methods, which are still gold standard for starting treatment in glaucoma. Then there are highly invasive trabs and tubes, which are reserved for the more aggressive, the more severe kind of glaucomas. Now, for the largest part, maybe till the last 10 years, there was a wide gap between these two treatments, and there were a lot of patients who were suffering and probably waited to deteriorate in front of us until we could justify to ourselves that, okay, we can go ahead and do trabs and tubes in these patients. Now, that scenario is going to change with the advent of MIGS. So with the kind of medication we start with, we are always concerned about it being cost effective as well as having the minimum frequency of dosing so that the compliance increases. We always start with monotherapy, and it's consensual that prostaglandins is our preferred choice of monotherapy to start with unless contraindicated. So let's take a look at this example. This is a patient with a borderline IOP of 23 and 24 with one PG analog comes down to 17, 18, which is a good enough 25% drop in his IOP. But now his fields have starting to progress. So what do you do? Now, if your monotherapy has brought about the kind of IOP drop it's supposed to, you add another treatment. Now, adding another AGM and still not reaching the target IOP is a sort of roadblock for all of us, because let me explain to you this simple math that it's only the first two drops which are going to bring about the maximum, most significant amount of IOP drop in your patients. The third and the second drop additively will only add about maybe 1 to 2 millimeters of mercury of an additional IOP drop. So you have to be looking at other options. There are various options for us to add on to PG analogs. Carbonic anhydrase inhibitors are thought to be the most suitable. We also have newer AGMs which are actually very, very good because their mechanism of action is completely different from what we have had so far. And if you want a more than 40% drop, combination therapies are your way to go. We have various available combination therapies, the most latest having 3 drugs, which is brimonidine, brinzolamide and timolol combination. However, although this is the most preferred treatment, we do have many concerns with using medications in our patients. Like 50% of our patients are non-compliant to AGMs, and these are Indian statistics. Many of them are suffering from severe side effects of the drops, severe ocular surface toxicity. Many of them are dealing with the cumbersome, confusing regimes which are different for right eye, different for left eye. Many of them are finding it difficult to put eye drops. So how do you tackle all these problems? Then there's also the problem of recurring cost, which is 7.7% of the total income of a patient's family is being spent on buying anti-glaucoma medications. So if there are these kind of patients who are suffering from side effects, non-compliance, physical inability, and or are just uncontrolled on maximum medical therapy, what do you do? So up until maybe a few years ago, we actually had no options. But we were, sort of seeing mild, moderate glaucomas, ocular hypertensives. These patients suffer with side effects and probably waited for them to deteriorate until we could justify that, okay, we can do trabs in these patients. Or in the extreme hand, we were doing brutally invasive surgeries in mild glaucoma patients, which also, let's remember, severely impair the quality of life of patient. Needless to say, the high risk of complications. So now this is a small algorithm that I follow. So if for any reason medications are not tolerated by the patient and the patient has a concurrent cataract, MIGS combined with a cataract surgery is the way to go. Mind you, these are only the mild to moderate or ocular hypertensive patients in whom you are not targeting a very, very low intraocular pressure, maybe let's say about 15 to 18, mid to high teens. If there is absolutely no cataract, maybe doing an SLT is a fair option. If it acts and repeatedly, if it needs to be done, the efficacy also goes down, and maybe eventually MIGS will be the option for these patients also. And for the more invasive, aggressive, severe glaucomas, tube and trabs still stand as gold standards. So we have a whole menu of MIGS available to us. The options that are available to us in India are only canal-based procedures. Otherwise, MIGS have been devised to target each and every outflow pathway. But in India, we're only doing canal-based surgeries of two kinds. One is either bypassing the trabecular meshwork by putting implants, or by stripping the entire trabecular meshwork and causing a direct communication with the Schlemm's canal. And also the fact that your patient could be doing well. But any patient, any glaucoma patient, mild to moderate, who is to undergo cataract surgery should be given the option of MIGS, because phaco alone is not able to sustain the amount of IOP drop that you're expecting in these patients, and not giving them this option is actually disservice to the patient. So how you do MIGS is probably something that you've already covered. We need to know what the MIGS stance is, gonioscopy. Also, the various kind of gonio prisms we have in the market. There are disposables, autoclavable. We will talk more about that during the workshop. Now, one thing I cannot stress enough is the proper understanding of angle structures. Now, I want to show you this video by an anonymous surgeon. You can see that the orange pointer is towards the trabecular meshwork, but the bang is being performed at the level of the ciliary body. So it's the root of the iris which is being cleaved over here. Now, this is definitely going to lead to disastrous hyphema and cyclodialysis cleft. So good proper understanding of angle structures is very important. And also, I think what sets glaucoma surgeons apart from anybody who can probably do MIGS, who's experienced enough or can do surgeries well, is when not to do a MIGS procedure. Now, when you need very, very low intraocular pressures, that is an absolute no for MIGS. Advanced glaucomas, normal tension glaucomas, stay away from these. Any sort of secondary glaucomas, except of course steroid-induced pigmentary or pseudoexfoliation glaucoma. Juvenile open-angle glaucomas also, we don't know what the anatomy is, what lies beyond the trabecular meshwork, so we don't want to delve into it. Elevated episcleral venous pressure, although MIGS has been tried extensively in PACG patients, its role is still a little questionable. Make sure preoperatively you have a good adequate view of the angle. There shouldn't be any peripheral anterior synechiae or corneal opacities. Again, let me show you one example of a mistake that I made. Now this is again a patient wherein a bang was planned after the cataract surgery, and after the first nick itself there was a lot of bleeding. So I washed it out, but still that blood clot is still there at the angle, and the view to the angle is completely obscured. So I cannot go ahead with a bang in this patient. So sometimes you may have to plan and re-strategize your surgery. If you have, let's say, a hard cataract, maybe do the MIGS before the cataract surgery, because a good visualization of the angle is the sole only important thing for you, which is required to do a proper MIGS. Also, be wary of patients who are on anticoagulants. However, the only literature which is available for the use of MIGS in patients who are still on anticoagulants is with iStent, which is deemed to be safe. We have one report of that. So now let me give you 4 unique clinical scenarios on where I did MIGS and where it applied and was very successful. So 4 unique indications. One is this patient who is a moderate glaucoma. He is well controlled on 3 medications, 15. He's doing well, but now he's developed cataract. So this is a glaucoma patient who now needs a cataract surgery, and you can see that he has been suffering from side effects for many years. His eyes are red, and so in this patient, what we need is, we don't need to lower the intraocular pressure. We are just attempting with the MIGS procedure that we can take him off a few of his anti-glaucoma medications so that the side effects are down. So in this patient, the MIGS and this thing was done, and the pressure is down to, we have a 5 months follow-up of this patient. He is now on no anti-glaucoma medication, 17 to 18 millimeters of mercury. We'll have to still follow him up, but even at the end of 5 months, his eye already looks a little better. Again, another young patient, young high myopes. All of us who do TRABs would know how scary it is to do TRABs and the failure rate with young high myopes. Anyway, to her dismay, she had to undergo TRAB because of a severe glaucoma. Now, even in the other eye, the IOP was uncontrolled, 29 on 5 anti-glaucoma medications. So in this patient, she underwent, it was a clear lens, so she underwent a standalone MIGS procedure, and the IOP is down to 10 millimeters of mercury with only 2 anti-glaucoma medications. This patient was one of the first ones that I started, so I have a good 2-year follow-up, and you can see that even at the end of 2 years, her visual fields are absolutely well maintained without any progression. Again, another case of pseudo-fake who was an ocular hypertensive, again, unmedicated IOP was 31-32, not tolerating his medicines, various systemic side effects, systemic health issues, family history of glaucoma. So even he benefited with MIGS procedure, and now at the end of 9 months, he is at borderline IOP, which is acceptable for an ocular hypertensive, but medication free. Now, this is a patient who is a gynecologist herself and has had a failed trap. So when she presented to me, she had had a cataract and trap done in both her eyes about a year back. And within 5 months, her anti-glaucoma medications were restarted. She was intolerant to all of them except just tafluprost, which sadly also went off the market. So she was left with absolutely no options. She even underwent an SLT, which started failing. And when she presented to me, she was at an IOP of 39, unmedicated, because she was not tolerating any other medication. So again, standalone MIGS in this procedure benefited her. This is absolutely normal disc, normal fields. 19 millimeters of mercury, 6 months follow-up, absolutely on no medications. This, you can see an OCT of the stent over here. So now these patients, they okay, so now if suppose you have a patient who is well controlled on a few medications, needs cataract surgery, they don't really need a glaucoma procedure but will benefit from a glaucoma procedure. And this, according to me, is success. If you bring down the anti-glaucoma medications of a patient, you give them freedom from a lot of things. 60% of our glaucoma patients are having dry eye disease due to the AGMs that we're putting them on, also leading to unsatisfactory visual outcomes after cataract surgery. Needless to say that you're also giving them better quality of life, better 24-hour IOP control, better visual field stability, less ocular toxicity, and also maybe a more suitable conjunctiva for trabeculectomy in the future, and also sparing them from the dreaded complications. Okay, so let's come on to the 2 MIGS procedures that we are going to highlight today. One is BANG, bent ab internal needle goniectomy. Now, the basics everyone is very well aware of. Very briefly, the principle behind BANG is that we all know that in primary open angle glaucoma, the obstruction lies at the level of the trabecular meshwork. So the idea is that you remove the trabecular meshwork so that there is a direct access of aqueous from the anterior chamber into the Schlemm's canal, and you de-roof the trabecular meshwork. Now the equipment used over here is very, very simple. You just need a gonio prism, you need a hypodermic needle, you need cohesive viscoelastic, and a regular incision. And it is 400 times less the cost of KDB. It is a low cost alternative to KDB. The design is the same. And this was, it's a brainchild of Arsham Shabani. He presented his report in AGS in 2019 and said that there was about 20% drop in intraocular pressure with patients that he did and followed up for 6 months. So this is a short video showing the BANG procedure. In this procedure too, the patient and microscope adjustment is just like any other MIGS surgery. A 1.4 mm temporal paracentesis incision is made. The creation of the needle goniotome is simple. A sterile 24 gauge 1 inch needle is taken in this case, and the bevel is bent short of 90 degrees, and a second slight bend is made at the tip. This design closely resembles a trabectome probe. Swan-Jacob direct gonio prism is placed using the non-dominant hand, and the angle landmarks are visualized and the trabecular meshwork is focused upon. The bent needle is then introduced till it touches the trabecular meshwork on the nasal side. The bevel and lumen of the needle form 2 cutting edges like double blade goniotome which excise end block tissue. Tip of the needle pierces the trabecular meshwork and the needle is advanced clockwise for 2 to 3 clock hours. Blood reflux from the Schlemm's canal is a sign of correct localization. The needle is then rotated 180 degrees and the tip reverses direction to move 2 to 3 clock hours more. You see that strip that comes out, that is the strip of trabecular meshwork you want to remove. So basically the tip of the needle is just entering the trabecular meshwork, piercing it, and the base of the needle that you've created rests at the roof of the Schlemm's canal, and you lightly, gently just cleave on about 90 to 100 degrees on the nasal side. And it's very important after having done the excision that you remove the leaflets. The trabecular meshwork leaflets can be removed either with a microforceps or during your viscoaspiration, you can aspirate the loose ends. Otherwise, there is going to be a problem of PAS if these leaflets readhere. This is how a de-roofed Schlemm's canal will look like. It's a white, bright band. Now, efficacy, there's very little in the literature about bang. Let's understand this. It's mostly propagated as something that you can start your journey with, but maybe you will not stick on to it because the literature available is very, very limited. We only have 3 to 6 months data, and that too are most of these publications are by the innovators themselves, and says that there is a good 20 to 30% drop in the IOP and also an average drop of anti-glaucoma medication by 1. Now this is, I've been doing bang for like a good 3 years now, and I've been able to collate about 30 cases so far that I'm following up over 6 months, and I've also seen a fairly 15 to 18% drop and also about 0.67 drop in anti-glaucoma medications, both of which happen to be clinically significant. Also, when stratified as mild, moderate, severe, it's doing very well in all of these 3 strata. But it does come with complications. It's not free of complications. Hyphema seems to be the most troublesome. But I've never encountered any sort of hyphema which I really needed a re-intervention for. It usually is self-absorbing. You can see IOP spikes, you'll see steroid response. A major concern is also development of peripheral anterior synechia. I think this is what is the biggest setback for bang, because peripheral anterior synechia happens in a lot of cases. In fact, in my cohort of studies, at least 50% of the patients have ended up having a PAS. And this probably occurs because those leaflets cannot be completely removed, or the leftover leaflets, they scar, they fuse together, and some sort of PAS does happen, and you have to probably reintroduce the AGMs that you were taking off from them. Okay, so the next mixed procedure that we're going to be talking about is the eye stent. Have we spoken a little about it? No. Okay, so eye stent is an eye-shaped device. It has 3 parts. One is the head, which rests in the Schlemm's canal, the thorax, which is to be inserted at the level of trabecular meshwork, and the flange, which faces you at in the anterior chamber. And it has a lumen of about 80 micron, and also along the head you have flow outlets of 50 micron each, 4 of those. Now it's made of titanium, heparin coated, it's delivered to you preloaded in an injector which is sterile and safe, and also MRI compatible. Now this is the injector, this is how it looks like. It has an insertion stainless steel sleeve. And the green button that you see over here can be retracted back to retract the sleeve. Once you do that, you're able to see the trocar, which is the needle that pinches the trabecular meshwork, and then the black button, which when pressed deploys the stent to be placed in the trabecular meshwork. So now again, the mechanism of the stent is also pretty much the same. The difference being that you're destroying less tissue, but you're also bypassing the obstructed trabecular meshwork for direct access of the aqueous from the anterior chamber to the Schlemm's canal. The flow is supposedly, can span about 4 to 5 clock hours on either side of the placement of stents, and even to the opposite side, to the temporal side, by about 25% dilatation, the Schlemm's canal has been seen. So you can see through this angiographic study in live human subjects, after the insertion of the eye stents, how the previously dormant collector channels have beautifully opened up. So this is the most physiological way of restoring your natural outflow pathway. Again, a short video describing the technique. The position, the entry, I think one mention that I should make over here is that when it comes to making the incisions in MIGS, it is not similar to how you would do for your phaco. It is a little more anterior. It's supposed to be a clear corneal incision so that there is no oozing of blood, so that it doesn't enter the anterior chamber and obscure your angle view, or it doesn't get stuck under your gonio lens and obscure your view. So it has to be a completely clear corneal incision. This is how it would look like, and ideally 2 stents are supposed to be placed about 2 to 3 clock hours apart. So this is a review on eye stent of mine. You can go through it for better understanding, and through literature we've come to know that eye stent with phaco brings about 17 to 39% drop in IOP with a medication reduction about 0 to 2. Standalone eye stent injects can also bring about your IOP to a little larger, which is 35 to 48% drop with a medication drop of about 1 to 2. The longest follow-up that we have has been by Hengerer et al., who presented their data in ASCRS and showed that there have been a consistent 40% IOP drop and a 60% medication drop at the end of 7 years in their cohort of 125 patients. So this is ahead of publication, my 3 months data, but so far now this has not been analyzed, but at the end of 6 months, I've seen about a 36% reduction in intraocular pressure of the 22 patients that I've calculated here, and a 51% reduction in medications. We also have newer devices available to us now. Now, interestingly, complications have been few, maybe. Hyphema doesn't seem to be the problem much compared to the TM cleaving procedures. However, I think the 2 challenges that you may face are underimplantation and trocar bias. Now, these are going to be your most limiting problems, at least when you're starting off. Also, with the Gen 1, I saw there was one case who had a blockage which was easily relieved by pilocarpine drops. Apart from this, IOP spikes, gonioscopically, hyphema, steroid response, all of this is like any other MIGS procedure. So last 3 short videos on seeing what kind of challenges you can face in surgery and how to overcome this. So this is something called underimplantation, which means that the stent falls off. It's not very well buried into your trabecular meshwork. Usually happens when the kind of pressure that you're supposed to push the injector into the trabecular meshwork with is not adequate enough, and you inject it little outside, so it falls out. So what you need to do over here is, if this was your first stent that fell off, inject the second stent first, then pick up the first stent like you saw in this video and reshoot. Then you can have the problem of trocar bias. Now, trocar bias will cause your stent to not be delivered, and let's understand. So when the needle is not perpendicular, the stent will fail to deliver. We have only 4 clicks, so you have to be extremely careful about not to have a trocar bias. Don't have sharp angles be perpendicular to your hand position so that it goes in straight and the stent can be delivered. It's okay to change your seat position so that your hand is perpendicular to where you're reaching. The last challenge that you can have is putting too much pressure, which is opposite of underimplantation. You could even cause overimplantation. Now, this happens when you're dimpling too much. When you dimple too much, either you will lose your stent into the Schlemm's canal or you will not be able to see it. Either which way, an improper implantation will mean that the surgery has failed. Your IOP drop, the AGM drop that you're expecting is not going to be adequate. So it's not because the stent is faulty, but also because of improper implantation. So too much overimplantation is something that you can watch out if you see that you're pressing too much and your cornea is creating folds. So your gonioscopic view will momentarily go away. So avoid that. In the end, I would like to say adequately counsel your patients preoperatively, never overpromise. Let's agree that we still do not have enough evidence in the area of MIGS. We cannot tell our patients how many AGMs we are going to reduce of them, how much of IOP drop are we promising to them. So all of these are gray areas. So do not overpromise. Just tell them that there is a blockage in the drain. With your cataract surgery, we're going to give you the added advantage of probably opening the drain. This is probably going to bring down your IOP. We're going to try to bring down the IOP. We're going to try to bring down the anti-glaucoma medications and see how the patient responds. Thank you so much.
Thank you very much, Dr. Saiban. That was
Thank you,
indeed a
ma'am.
very, very interesting and informative presentation. So, since we're running a little late, I think we'll move on straight onto the hands-on, and you can
Right.
ask her whatever questions you wanted to ask when you're actually doing it hands-on. And please remember, after you've finished your hands-on, don't forget to take your certificates from Dr. Surajit Chakravarti, the Secretary of KO. Okay? Thank you very much. So
Thank
we move
you.
on
Thank you so much,
right
ma'am.
away to the hands-on.
Through the cornea, cross the pupillary margin, put it on the iris. তারপরে আস্তে আস্তে, once you cross the pupillary margin, you can just pull it back. So this is exposed. Can you make out? Yes. The thing is exposed. Then you go up to the trabecular meshwork. Then just press on the trabecular meshwork. Put your finger here and then fire.
Okay.
Then come back because you have to do a second side. So let the trocar be outside. Then you move to 2 o'clock or 3 o'clock position, and then once again you press it. Once again to the front.
will be injected.
So the fang remains out till you put the next one also.
Next one.
Sit down and do it. I think that will be much easier.
Height में नहीं आ रहा है. Height में नहीं आ रहा है.
এই করলে এইটা এমনি করলে
ফ্যানটা খুলে যায়।
তারপর এইটাতে ঢুকলে এই আর এই
দুটো pillow বা একটু কিছু বেঁধে
So it's like this, go inside,
গো ব্যাক
Pull it
পুরো
back.
ড্রাগে হ্যাঁ
go closer and then
1 মারো
press and then.
and now shift to the second bas
Lock it in.
What we also say, once you touch the trabecular meshwork, click here, don't release. Come out and release.
ও
Okay.
Otherwise কি হয়, অনেক সময় আপনি যদি পুশ করলেন, ছেড়ে দিলেন, it will hold.
আচ্ছা
It will come with the
With
device.
the device.
With the device. So what
Right.
you say, go, click, wait for 1 or 2 seconds, come again, release. Once you release, you will see the another is already taking place.
All right.
Or the second one.
Once you see the pupillary margin with the index finger, you have to drag this behind. So what happens? Your trocar is exposed. Once the trocar is exposed, you know where your trabecular meshwork is. You go there. With this index finger, you have to fire. Fire
have the
करके
stable
leave it there
hands
for
for
1
it.
or 2 seconds.
Where is
The device. वो निकला इसमें नहीं है निकलेगा. So ये आपने fire किया. Once you fire.
this will pierce the trabecular
Trabecular meshwork. Once you fire here, one of the stent is already inside. So wait there for 1 or 2 seconds. Don't release your index finger. You come out. Release it. Go to the next point. Fire again. Wait for 1-2 seconds. Then you come out and then total.
So now I can see those red areas, right?
So this is the main thing. The
We have to
coming,
target there or
releasing
on
the
the red.
inside.
only on the
after
red.
ठीक है, we will be able to ये जाते हैं ना काट तो फिक्स काटा तो फिक्स अब आई मॉडल such a way that whatever you want you can so whatever practice speaking একটা ইয়ারকে জিনিস দেখুন এই practical challenge practical challenge बेटा hand is coming here फिर मैंने visualize नहीं हो रहा इसको हम कुछ नहीं करके go out of the see new procedure
Registration.
very wider with yes and it becomes even very wider
till I don't
Now you do the zoom. Do you zoom from foot pedal?
So you have to have the right.
And then fine focus.
All of you are learning surgical seminars. I finished or just started? We haven't done. That's okay.
Yeah, theoretically I am telling that practically they can have.
I can put another one.
Yes.
5 of them can finish.
Select the channels as input, light, right? So 90 to 100 is the minimum, to maximum 120. You cannot reach from 180 to 120. So you can use anything from 24 gauge to 27 gauge. 24, I personally feel is a little too large, so there is a chance that you will injure the further stems, the nanobones. It's either to take the 26 gauge, now the half inch 26 gauge will not reach to the opposite side. So I don't know why this is kept. You have to have, and this 26 gauge doesn't come in a 1 inch tube. That's again another challenge. So you have to have 1.5 inch 26 gauge. Or then still is 27 gauge. Not very hard. And it's opposite to what you do first. 62. Under the microscope.
So once you are sitting temporarily, that will help you access your general side of the question. Visualization.
So now this is your needle. This is the bevel. Normally for making a cystitome, you will rotate it in the opposite side, right? This is the bevel. Okay, this is it clear for you? It's not clear for me. Okay, so this is the bevel. Now what you're supposed to do is turn the bevel from, hold it from the center and turn it to a little less than 90 degrees. The line. This needle holder is
and when you are feeling the problem, don't totally like a cataract actually. Put at a single place. Over the cornea.
Towards the bevel side.
And what you also want to do is blunt the tip of the needle. Now you don't want this very sharp thing going in because you can injure it. So you can see that now there are two.
Feel that completely. So it will form now. Very tight, so that there is
How much you pierce with the needle tip? Yes.
just enough so that you should like I showed you keep sipping this. Thank you so much. You should just be, thank you. You should be seeing the bend of your, the trabecular mesh. So you just pierce, as soon as you pierce, you make it straight. Like, let's see again.
Do we remove the traffic in the
At the end of it, when you see it also, or you just pull it off if you're not sure, you can reassess once you've done the IA to see if there are any loose deformations. Even if you do something in the extreme corners, even if it adheres, at least you have a good 100 clock hours of, not clock hours, 100 degrees of conversion.
In your making cases, you
So if I'm doing after cataract surgery, again I will go pilot. But if I do a mix before the cataract surgery, I dilate the patient and then which is very hard cataract. Or even if you feel that your lens is bulky, you need a little more space, you will do it after cataract surgery. Anywhere where you're also anticipating some trouble, let's say you don't you don't want to promise the patient a mixed procedure and then end up having a complicated not doing a mixed procedure also. So you do the mixed procedure, if the chamber is well formed, then do your cataract.
have you ever had this incident?
You have to still deliver the second stent, otherwise both of them will just...
short, 3-4 is black.
So even the second one will push out along with the first one. So first one will go into the stent canal, second one will somewhere be around.
And third, you can put that thing back again.
Yes. Once you've made the second shot with the second stent, you rethread it. Now again you have 2 clicks to re-implant the first stent which has fallen out.
In the AC.
Ideally, yes. I've burnt my hands by trying to take it out, and they do recommend that though, that you take it out, keep it in a white piece of this thing. It's extremely tiny. Extremely tiny. Once you actually take it out of the eye, you'll understand, because here it's 100 times the magnification that we usually use for our phakic. It's extremely tiny. I have spent minutes to maybe like 20 minutes looking for the stent in the eye itself. So the draped eye, I took out with the forceps, alum forceps, and somehow just lost the grip. And it just fell on the conjunctiva, it was right there, but I just couldn't see it. Because you have to rotate your field from here to there. It took me a good 15 minutes.
So when you are threading it in the AC, what is your...
If I don't put a little pressure, I'm not seeing very clearly.
There's a
So you can't do anything with your left hand, you're holding the
you
conjunctiva.
have to just go like
You
this.
have to tease the stent so that the lumen comes facing you and the trocar has to be rethreaded.
Why dilatation?
Not dilate the patient at all. After you do mix, then you put epinephrine and just dilate the patient, but that dilatation is not as great as a regular pre-op dilatation. So in patients where toric is planned, you want a very good dilatation. So now those patients, I dilate the patient because that is not a deterrent to you doing your mix. Your angle is very open. It's not going to shallow your angle. The only challenge is you may injure the anterior lens capsule. That's the only one thing which I will not recommend, because you can damage your anterior lens capsule, then it's downhill from there. So I dilate the patients now, but if you want to do a cataract surgery following your mix, best is not to dilate preoperatively. After you've done your mix, then just put some epitrate and dilate it on the table. Intracameral epitrate. So I think let's start by practicing how to make the gonio needle, and then
It was not
Try to do in patient. That will be easy.
Like you know that it's not, it's the ideal point, it's the ideal point.
It's not available. It is available, but not recommended because SX is better than this actually.
Okay.
It's already free. It's already free. So you can. इससे क्या होगा कि आपका चैम्बर भी
No, I just wanted to push visco.
Safety is of paramount importance. So you don't that it may feel, let's see, we at least avoid long the more invasive surgery. Safety is essential. Safety is essential. If you're having side effects, intolerabilities, again another surgery.
If the visco is working, I will take this out.
Just locate the incision. बाहर चला गया.
Illumination be.
No, not this. Always take the view, no? Keep over the illumination the bottom.
No, angle पे ठीक नहीं.
Now take the fine focus. এখন ঠিক আছে. Do the fine. না কমবে না. এটা steady রাখানোই দরকার. Because that's how the
But I'm trying to get the view which was previously there.
That you put some visco, then only will be. Yes, go on pushing. Don't take the camera out. Yes, come on. Now what you do, leave it. Go with the needle. Don't do anything now. Go. Now actually, red line. But you are.
এটা তোমরা গণিত প্রেজেন্টে নিয়ে এসছো আর আছে তোমাদের এখানে
গণিত প্রিজম মানে আপনি কি অর্ডার মানে নেবেন একটা? হ্যাঁ হ্যাঁ আমি পাঠিয়ে দেবো একটা।
পাঠাবে না এখনো আছে তো
এটা তো রয়েছে, এটা তো আমারই। আপনি ওখানে গেছিলেন এই গণিত প্রিজম করেছেন? ওইটা তো ওখানে নিচে গেছে।
এটা চালিয়ে দাও।
হ্যাঁ
এই প্রমোটিং এর না আমরা একটু বললাম ফ্ল্যাট কিনেছি দাম করেছো আরেকটা নোট প্রত্যেকটা ইন্ডিভিজুয়াল So after I
হায়ার ম্যানেজমেন্টের মানে গভর্নমেন্টের সমস্ত
Connect to them, they will get it. Plus the accessories. Direct. Indirect is what you need. सर्जरी को चेंज हो रही है तब आवर retina because we don't provide this because this is disposable. So I can try to
We have to operate here. So we have to operate in this area. Pardon? We have to operate in this area.
If that red color you are able to see now, the stents are there. That is the area where you are going to all the surgical lenses.
what's going on? Place where I want to. ওরা স্ট্রিপ করে না ওটা টানতে হয় এডিবি করার পর লোকটা টানতে হবে আপনার একদম স্ট্রিপে কারণ একটা কনসিস্টেন্সি আছে ওটা স্লাইমি লেয়ার কিন্তু কনসিস্টেন্সি আছে এমন নয় যে বেরিয়ে যায় ওরাও কোনোদিন হবে না যেখানটা মারলে সেখানে কিন্তু ব্লাড বেরোবে কোহেসিভ ডিস্কো কেন ইউজ করতে হচ্ছে কোহেসিভ ডিস্কোকে ইউজ করতে হলে আপনার ব্লাডটা ধরে রাখবেন আপনি যদি করছেন না হুট করে ব্লাডটা উজআউট করবে যখন আপনি আয়নে করবেন তখন সেখানে দেখবেন ইউ গেট দ্য ব্লাড লুজিং আউট অ্যাকচুয়ালি আয়নেতে উল্টা ব্লাড বাড়বে বিকজ ইউ আর ক্রিয়েটিং আ হাই পাওয়ার ব্লাড উইল কাম ফ্রম আয়নে So never do within the procedure if you find a lot of blood and you think we clean it up or we got one
That limbus is going well from don't do that pressure actually. If that otherwise what will happen? The strap.
There is a chance the hyphema is very high. That's why cohesive disc or tamponade effect for 2-3 days. Sometimes it have 2 weeks.
Wash it up.
No, it will go on.
Yeah, but that is the
I still never do it.
I still never.
You should not. Actually, if you keep it, then its IOP-lowering efficacy from the next day will not be there. It will come. Because with the hyphema, you have to cover it up. You have to make yourself safe. Otherwise, I still need to require. We take it around hyphema. Yeah. ক্ষেত্রে আপনাকে রিস্কই নিতে হবে রিস্ক রাখতে হবে ইউ ক্যানট এফেক্ট
This is not a hemo, something for this biohydrolysis from the biotech. Like that. But they have a value. I don't know, I'm not expert. That is the product. Better to अभी तक तो नहीं सप्लाई किया ना बट इन ट्रबल रेडिंग्स बेनिफिट रेशियो
হ্যাঁ তখন ওই জন্য দিতে হচ্ছে স্যার ওই প্রসিডিওরগুলো কোথাওই ইন গ্লোবালি they have never been successful or not in India because of the cost. We don't stop. Last month, we stopped all the
because KDP তো কোনো ডেটা নেই না KDP because they don't have data long term data so है ही नहीं you have challenges they said that why should I pay so much amount of money and you come up with a drug that will charge me you then have to pay US everything has to be paid for the government
Bubbles as to the current technology so this is not going to
ना HPMC पर कोहेसिव इसको बात नहीं not कोहेसिव इसको is the only thing otherwise you have trouble even visco both were very big
instrument is
effect আছে
is there any other instrument no আরেকটা আছে এগুলো সুতুলার
এই যে এটা
ये है ना
yeah better
so you can try this
পরিচিত ওই এটা কাভারটা সরিয়ে নিতে হবে এটা হ্যাঁ এটা দেখ
এইটুকু নিউট্রিটা আছে ওপেনিংটা একদম এজে চলে আসছে না
ট্রাফিক্যাল মিশর দিয়ে টাচ করাটা প্র্যাকটিস করা আছে ভেতরে জিনিসটা নেই
কেন নেই
ছিল
আচ্ছা আরেকটু উপরে আছে
দেখা যাচ্ছে
So wait for some time, you deliver and you press it and then
হ্যাঁ এবারে
keep pressing, your toothbrush will come out open.
ট্রানজিশনটা ঢোকার পর
এই করলাম
Keeping this
যাওয়ার পরে এটা
once you short, you release this. When complete, come out. Once you've come out here, you close it and then come out. After shooting, you have to release the
আচ্ছা তো সাইড
Schlems canal and then it will get delivered in the ciliary somewhere, in the supraciliary space somewhere. You can't do it.
And have you ever had a thing that it is supposed to happen, but there's actually one?
So, the cheating now,
Packaging error.
so I thought so.
So one has to be a standby item.
Oh yes. One has to be standby because I think more so than the manufacturing error, the problem is if suppose you had to our bias and
যখনই তুই 10টা করে ফেলবি তো আই থিংক
it is always good to do a inferior nozzle কেন কি
লিড করলেও ওই দিকে যাবে
হেড টু টো বেঁচে যাবে কিন্তু সত্যি বলতে এটা টিপ যেটাই করুন না ইউ ক্যানট হ্যাভ এ ট্রকার বায়াস যদি আপনি ওই হাতটা নিয়ে ঘোরাতে যান না তাহলে ট্রকার বায়াস
so when the click happens, there's some compressed air that pushes the stents.
it's a mechanical
Mechanical needle only. Coil. So when you have those toy guns, no?
you cannot do it like this. It is like a drum type of
Yeah, there's a bent hair.
there is a thing which is pull it
It's a lever.
ट्रिगर जो आप पहले के ज़माने में वो बहुत गादा बंदूक थी ना ওরকম টাইপের ব্যাপার এটা জানি ইনফিনিট সো ইউ হ্যাভ টু ইউ আর নট
But this is a fair question. Who chose the clicks to be 4? How did you come down to this number?
because it was so basically no it is nothing to do with 4 we have seen that most of the places 2 or 3 is required
হ্যাঁ এখানে দেখবেন
হ্যাঁ 3 to 6 or 3 is required and actually we have given one for each stand
You manufactured it that way without any experience from surgeons, no?
No, that has been done.
What behind
That has been done in
focus করতে হবে
कुछ तो किया होगा, I don't know, that I don't know.
Correct. I didn't get this concept of 4 clicks. Can you repeat?
अच्छा यहाँ पे 1, 2, 3, 4.
ওখানে আসবেন
কমফোর্টেবল ভাবে করতে পারবে
But what is the purpose of the
একবার ওইটা দেখতে দেখুন
ওয়াইফাই কানেক্ট না দিলে হবে ব্লুটুথ ওয়াইফাই তো হ্যাঁ
আমি বলছি এই স্টেনটা ইজ ফ্রি ফ্লোটিং এটা মানে আমার স্লিপ করে গেছে
এটা
হ্যাঁ এই যে স্টেনটা ম্যাম এবার আমি এটাকে উইথড্র করলাম এইবার আমি
ওখানে ঢোকানোর চেষ্টা করলাম
নিডলটা ওটা নিয়ে করছি এই ঢুকে গেল কিন্তু
এবারে বার করার চেষ্টা
এইবারে আবার ফেরত গেলি
এই না এইবার যেটা বলছি সাইবান যে এটা অটোমেটিকলি হয়ে যাবে
সাকশনে কিছুটা
আমি না বিকজ ইট ইজ অলরেডি ইমপ্লান্টেড আপনি এটা সাকশন করতে পারবেন না
না এটা তো ইমপ্লান্টেড এটা ফ্রি ফ্লোট করছে এটা কিন্তু লেগে নেই বেরিয়ে এসেছে
আপনাকে ড্রপ করে দিতে হবে যে আপনার কোহেসিভ দেওয়া আছে আপনাকে ফোর্সিভ দিয়ে ড্রপ ইট
ও আই টু ড্রপ ইট
আটকে আছে তো ওটা অ্যাপ্লাই করবেন কি করে
না
না
ফ্রি ফ্লোট করছে one second.
না ও ড্রপ করতে পারবে
This is free floating. There's a stain which is there and it's free floating. Okay. So suppose I go there.
There is a lag.
The needle tip is now gone.
No, he initially went into the hole, but it didn't come automatically.
It just went inside.
Rethreaded and then puncture at the same point or another point if that is
But
not
it's hanging loosely. But it's not going in.
then you gently so what you do is then
After this procedure is completed, so what are the post-operative medications that we use? Any anti-inflammatory steroids?
post-operatively you use everything that you use for a catheter. You can give cyclopentone.
Yeah, side.
NSAIDs, you give antibiotics for 2 weeks.
See, now with this needle, I'm threading it. So I've gone inside. Now what do I do? So
Now you pick it up.
Yeah, so what should my hand finger
Bring
movement
it back.
So
Try
come
to bring.
out. Are you
try-
pressing on something?
No,
or
I'm
you're
not
in the
pressing.
air?
Try to bring it back.
So
Try
once
to
you
retract your hand.
now
Yeah.
you come back a little.
I come back a little.
Yes.
Raise it up a
Got it.
little.
Okay. No, ma'am, it asked
slips
Okay, I got it,
inside
Simon.
gravity.
All right. But this is still there. It's embedded in the
will
mesh.
be at the tip.
Got it.
So it's not free floating.
It's not
free floating.
That's why I asked you. Who's the mesh?
হ্যাঁ বেরোচ্ছে
না না
Ma'am, asked না ওটা
ওর
মাথা-
access নেই।
তাও করা যাবে মানে এরকম না করা যাবে না
ঠিক জায়গায় পজিশন হবে
Position হবে।
আন্ডার পজিশন হয়ে গেলে তখন অসুবিধা
Once
So
you
you
try,
can try, bring this, tease it out, let it fall, try and rethread it.
once it is free floating, then it's not that easy. It will be moving 360
No,
degrees.
but it's in the cohesive, no? It will be stick like this.
No, it will be moving
See, now the
360
thing
degrees.
is that no sir, actually if you have a cohesive viscoelastic, your chamber is never free floating.
No,
Like
but what I am
it's
saying is
everything is
when it
stiff.
will touch that stand, then it will move.
We are saying it will not move that much, but it
Now
will still have
over
that
here,
opportunity.
if you just leave a stick
it's not so
and
easy.
then try to put it on
এও স্লিপারি এও অয়েলি আর তারপরে ওই এটা স্পঞ্জ
এইটা বলছিলাম মানে procedure-টা করা।
এই কেসে ছাড়তেও পারবে না ফ্রি ফরেন বডি আর লাগাতেও পারবে কি না টেনে বার করে টেনে বার করলে কি ফোর্সেপস ইউজ হয়
Retina forceps. Retina forceps. Retina forceps.
Titanium, ma'am.
It has happened.
But retina forceps তো glaucoma surgeon-এর কাছে থাকে না।
যেটা বলবো আর এটা লাগাই না সেটা ছাড়া একটা স্ট্যান্ড বাই
Exactly. That is very important. That is very, very important. We always say to give two.
চোকার ফেলিয়ার হতে পারে পিপল তো কন্ট্রোল করে আমি তোকে মাইক্রোফোসেপস দিয়ে বার করে এনে বাইরে ট্রেন করে খুবই ডিফিকাল্ট বিকজ তো স্লিপারি মিডিয়াম
পিছনটা তো সার্কেল স্টেনটা এবার যদি আপনি স্টেনটাকে পিছনটা সার্কেল লেগে বের করতে যান, এটা আপনি যতই শক্ত করবেন ইট উইল অলওয়েজ বায়াস। এটা শক্ত করলেও আপনার কিচ্ছু হবে না, পিছনটা তো পুরো সার্কেল,
মানে অনেকটা এরিয়া যতই হার্ড মেটেরিয়ালটা
হলেও কিন্তু অলওয়েজ বায়াস।
But that is a problem.
This is the right.
Correct.
Rethread it, now lift it up a little so that by gravity
now
it
it is
slips down to the capillary.
Now it is free floating.
Okay, you have to lift it up so that by gravity it comes down.
Just slip down. Now puncture the trabecular meshwork. Once you puncture the trabecular meshwork and hit it till the point where the trocar is, you push it back, then you inject.
There is a lag in the Madam, the eye has moved. You mean to say it's not getting... No, but it's not moving with it.
Now what do you think?
Now you puncture in the trabecular now, so that now the tip of the sleeve is there. Because after the it's not stable. Real life. So now do you see that ये थोड़ा और पीछे चला गया है? Can you see this?
Yeah.
So when you puncture the trabecular meshwork, it will push the stent back inside the sleeve, and then you have lost the clicks also. Now I can't click anymore. But when you click now and release it, yeah. So right now the stent is inside the injector room.
ম্যাম যখন ওটাকে তোলা হচ্ছে ওটা লাইটলি তুলে নিয়ে চলে যাও কোনোভাবে গিয়ে আবার এখানে বসিয়ে দেন ইউ ক্লিক ওট আবার নিয়ে যাও, মানে এখন আর কিছু দিয়ে সাকশন করে ভিতরে ঢুকে যাবো হবে না, জাস্ট ম্যানেজ ইট সামহাউ টু জাস্ট টিপ ইট দেয়ার।
আপনি করে কিনবেন, সার্জেন্স প্রবলেম বাট কেন পেশেন্ট প্রবলেম।
আচ্ছা ফার্স্ট থেকে যদি না যায়
হ্যাঁ, what is it? The first is not
This will leave on time. May not land.
বুঝতে পারছি
এটা আসছে